Hi, I'm Jonathan.
Hi, Amy.
And it's time for Cut to the Case. And Amy, I've got something I need to talk to you about. I'm a bit frustrated about it. It's ultrasound in cardiac arrest.
Right.
Okay,
Talk to me.
I'll talk to you. Paint the picture. Standard cardiac arrest. Compressions are going on. The whole team's there. Everyone's doing a great job. And then we get to the rhythm check section.
Mm-hmm.
Ultrasound goes on. I see the rhythm, it's VF. The ultrasound person, they're taking a long time.
Yeah.
And I'm just wondering, and they're slowing things down. I know it's VF, it's time to shock. It takes me, 2 seconds to know VF, shock or rhythm. But the ultrasound person's on there trying to get some information. So what I wanted to ask you was, what's the utility of ultrasound in cardiac arrest? When should we use it? What's it good for? And also the timing. Is there a specific time we should do it?
Sure. Well, I'm glad you brought that up because there's a lot of things to talk about there.
There's a lot.
First off, I would say it's probably
And
the
it
most.
annoyed me.
Yeah, I can see
Yeah,
that.
I'm frustrated, Amy. Yeah.
It's probably most useful in cardiac arrest scenarios where there's a non-shockable rhythm.
Yeah, for sure.
I'll leave with that.
Yeah, okay. Yeah.
Because what we're looking at is that we're trying to see ultrasound's trying to determine if there is a reversible cause of the cardiac arrest,
Yeah.
and that's usually the PEA, your asystole caused by tamponade and massive PE. They're probably
Yeah.
the two
Because
most
if it's a
important ones.
VF arrest, right, or a VT arrest, shockable, we know what the reversible cause is. It's the rhythm. Shock them out of the rhythm.
That's right.
That's the reversible cause,
Yeah.
right? So I see it, I shock it. But what you're saying, if it's PEA, the defib's not really doing much, right?
Yeah.
So so we have a brief period of time where we can reverse the reversible causes, and ultrasound's going to help. But
Yeah.
how?
That's right.
Yeah, how?
So you brought up a really important point about trying to avoid pauses during the rhythm check. And actually there are studies that show that when you use point of care ultrasound for that, it actually can increase the time off the chest anywhere between 4 and 8 seconds, which we're trying to
Yeah,
avoid.
well, that's what I observed. So that's
Yeah.
what I was watching, and that was what was frustrating me, because it was like, what
Yeah.
information are
You
you
don't want
getting?
that. It's going to lead to poor outcomes.
So tell me, in which kinds of PEA arrest is ultrasound actually useful?
So really, probably the most useful are the narrow complex ones.
Mm-hmm. I mean, there are different ways to think about a PEA arrest, but when I think narrow complex PEA arrest, I'm thinking it's an RV problem. The RV is usually a mechanical issue, which usually means I can fix it, but to fix it I need to diagnose it, and the causes that I'm looking for are going to be things like tamponade, massive PE, and
Your obstructive shock.
yeah, obstructive shock, right? Yeah. And tension pneumothorax.
Yeah.
Right? So that would be the things. So I can find those on ultrasound. Yeah. So the narrow complex, that's it. Yeah.
Yeah,
Okay.
they're the
Right.
ones to
Yeah.
really think about using the ultrasound in cardiac arrest.
Mm.
And then it's so the next point is, how do we go about trying to minimise that time that's spent doing ultrasound when we're looking for those things?
Yeah.
So I guess the main point is preparation is really key here. You really want to have your machine ready to go. So you're talking about the right depth, using making sure that your gain is appropriate, and using the right probe. So with this one, I would probably advise using the phase array or cardiac probe because it's got a smaller footprint.
Okay,
and
so
it can get
that's a
better
little
views.
job.
That's the
Yeah,
one.
got it. Okay. Yeah.
And then other things that I think about is, this is if someone's in cardiac arrest and they're obviously an extremist. This is a case where you would use your most experienced sonographer in the room to try
Yes.
and get the best
Yeah.
views.
So it's not time to learn.
Yeah.
It's time just to get in there and do it.
Yeah, I think so.
And actually, what I'm hearing is you're probably getting all this ready before the patient even arrives. Like if you have preparation time,
Yeah.
you get your most senior person in, you get them to fit or get the right probe, get things kind of sorted
Yeah.
before they arrive.
That's right.
Yep.
And
Okay.
it can be a bit challenging because when you're preparing your ultrasound, it's going to be on the same side as the person doing the chest compressions.
Yeah,
So it's a bit tight for space.
A bit tight, gets in the way. Yeah.
Yeah.
Okay, gets in the way and takes time. So, and it's good for the narrow, complex ones.
Yeah.
Because it's going to tell me tension pneumothorax and tamponade and massive PE. Got it. Okay.
That's right.
So, well, actually, and before we move on to the other bit, if it's a broad, complex one, ultrasound's probably not going to tell me that much because a broad, complex PEA is usually a heart's not contracting well.
That's
So
right.
that's usually, dead myocardium from ischemia, so massive AMI, or
Tox as
toxin.
well.
Okay, so probably not going to tell me much, or hyperkalemia.
Yeah.
So
Makes sense.
less useful.
Yeah.
And in those situations, you know what? I don't think ultrasound. I think bicarb. But that's another story. Okay,
Right.
so that's
for
another
the
story.
next the next
That's the
case.
next one. But back to the arrest, right? So the arrest is going on, compressions are going on. We know there's this pause in CPR that's damaging. We want to minimise it. So take me through how you actually do it. Let's go
So-
slow-mo. What's that
Okay.
ultrasound person doing?
So say you would have your machine ready to go, the right probe, right depth, right gain.
Got it? Yeah.
And then you're actually going to try and get your best image while the chest compressions are ongoing. So you're going to go in the
Okay.
subcostal view,
Yeah.
because that's away from all the chest compressions, or if there's a mechanical device there, it'll be away
Yes.
from that too.
Yeah.
And you're actually trying to get your view whilst that is ongoing, so that you're ready to go as soon as that pulse check starts.
So won't it all be kind of moving?
It will be moving,
It's moving, yeah.
but you can kind of get a rough idea that you're going to be in the
Yeah.
right spot.
Yeah, okay. So you're going to have a moving image, but I think from what you're saying is the minute it stops,
You're good to go.
I'm good to go. Yeah,
Yeah.
okay, all right.
And then a bit of advice is you can actually just to remind yourself that you're not going to blow out the time trying to get the images and prolong the time off the chest. You can actually set your video loop to about 10 seconds, and that's what the guidelines said pulse check should be max.
Okay, yeah, all right.
So that you know that you're not going to go any longer than
So you
that.
can even tell the team leader, I've preset my video loop to 10 seconds, so I'm not going to be more than 10 seconds. So Jonathan, don't worry.
Yeah.
I'm not going to be more than 10 seconds, and I'll get the picture. But
Yeah.
you're probably even quicker than that, won't you? I think.
Yeah, you should
Yeah.
be, because you're actually not interpreting the image while you're taking it.
Yeah, and that's a key point, isn't it?
Yeah, so you're just
So-
gonna get in,
So the
take
thing's
your
going
video
up
loop.
and down, the CPR is happening. The CPR stops, right?
Yeah,
Yeah, and then what do you actually do then?
literally just press record
Okay,
for
Yeah.
up to 10 seconds maximum,
Yeah.
And then come off the chest.
and then you get off.
You get off, you get away.
CPR goes on, or the patient gets a shock, but it's probably not going to be shockable because we're talking PA.
Mhm.
Maybe some adrenaline goes in, and then what do? Do you step away?
Yeah, so
Or-
you can actually just bring the machine away. You can ask a colleague. Both of you can look at the images together to determine what's going on with the video that you just
yeah,
took.
okay. And that makes a lot of sense. You can even probably share that with the team leader.
Mm.
You can even, hey, look, this is the image I'm seeing, team leader, because the CPR team are doing the arrest, keeping the patient alive, and there's ventilation, and there's compressions, and there's a defib person, but the leader is thinking of the H's and T's. The ultrasound person has now got the information. You can share it and go, you know what? I think it's this, or I think it's that. Yeah.
Yeah,
Yeah,
and
so
there's
that
a
works.
few things that you definitely need to look at, and the reversible, in terms of reversible causes. First is there a big pericardial effusion, suggesting it's tamponade.
In which case you'd
You might want to proceed to pericardial
and you'd
sepsis.
use the ultrasound.
Yeah.
All right, that's another use. Okay,
Yeah.
I'm almost getting convinced. Yeah,
Then, or else is it massive PE, and
Yeah.
you've got a dilated right heart, and
Yes.
you might need thrombolysis.
And oh my God, you know what? You could, if you had time, you could look for the DVT.
Yeah.
To confirm it.
And you can do that during chest compressions.
Yes.
And thirdly, it actually might show you that you've actually got a fibrillating heart, so it might actually be fine VF rather than a true
Yeah, and it's so
or
important.
assist.
Yeah, so you may have one of those situations where it's actually fine VF, you can't tell, and that's a very different prognosis.
Yeah.
Yeah, so you can shock that.
Yeah. And also if it shows you that there's cardiac standstill, that's really good for prognostication. So you may not want to continue resuscitation efforts if that's the case.
Okay. So we've got the reasons, the time, the situations where to be useful. So we're talking PEA, probably narrow complex, because it's obstructive, an RV problem that you can fix. We've got the timing of when you actually do it. We've got the prognostication stuff as well, and the fact that you could probably find VF. Anything else? Ultrasound? Cardiac arrest. I've stumped you now, haven't I? There's one more thing.
What were you thinking?
Yeah, no, I was thinking, sometimes you just can't feel the pulse, but you think the patient's alive.
Oh yes.
Yeah. There's a pseudo PEA thing, and if there's signs of life, obviously they are alive. But sometimes it's really hard to feel the pulse. Do you ever use the ultrasound to feel the pulse?
I often do, just because you said it's actually pulse checks they're unreliable, they're inaccurate, and depend on for example, the patient's body habitus. They might be really tricky to feel, so it's useful too.
So it's probably a body habitus situation where you think, actually you should have a pulse, but I can't feel it. So then you'd use an ultrasound to actually show some pulse or flow.
Yeah.
Yeah. Okay. Well, that makes sense. So lots of things. So I'm almost sounding like I'm a convert. I think I can see it's useful. I mean, I have been using it, and I like the idea of having that time-limited boarding and letting the team leader know.
Yeah, it's a good reminder.
And there's one other thing that you were going to show me, which is this algorithm.
Yeah, there's just well, there's many protocols to help you with using your ultrasound and cardiac arrest. This particular one is pretty good because it just gives you a nice little timeline about what to do for each rhythm check. The first point is your preparation phase, and that's when the defib is charging. You're popping your probe on the chest, so we're trying to get that subcostal view. And then it's a pause phase, and that's during your pulse check.
Yep.
And then we're going to record just your clip for a maximum of 10 seconds.
Yep.
And the next stage is when CPR recommences, and that's your review stage. And that's when you're saying, is there cardiac activity? Is there actually any abnormal findings I need to address? And then the last one is, do I actually need to intervene? So is it the management change? Do I need to do anything different in terms of managing the
Useful, I like it. Let's get it up in the resus room. Okay, Amy, well that was ultrasound cardiac arrest. Thank you so much. That was a lot of fun. And see you next time. Okay. Bye.